mastocytosis, chronic renal insufficiency, myeloid diseases, and also others. So what do we know about hereditary alpha-tryptasemia so far? Actually, it is a normal genetic variant with a prevalence of 5 to 6%. However, it may become symptomatic. We don't know, but maybe because of a special reason like an infection. And these symptomatic people show very variable phenotypic expressivity. Most of HUD patients show a slightly elevated BST level or are at the high end of a normal BST level between 8 and 11.4 micrograms per L. In median, they show a BST level of 11.7. And what was also known is that HUD was associated with anaphylaxis, with idiopathic anaphylaxis and also insect venom allergy. It was also described to increase the mast cell mediator symptoms, especially of mastocytosis patients. It was associated with functional GI symptoms, with muscle and joint pain, neuropsychologic symptoms, and others. So how can we explain pathophysiology of HUD? You know that mast cells store mature tryptases as homotetramers in their secretory granules. And since HUD patients form more alpha-tryptases, they contain more heterotetramers. And if these heterotetramers are secreted, they are able, at least in vitro, to stimulate specific receptors, such as the EMR2 on the mast cells itself, leading to autoactivation of these mast cells, or they stimulate PAR2 on intestinal epithelium, and they can thus lead to increased vascular permeability. HUD patients do show quite a lot of GI manifestations. Up to 90% of HUD patients do present with GI manifestations. And about half of these patients do show irritable bowel syndrome-like symptoms, such as cramping or pain. Actually, it has to be known that IBS syndrome is not increased in HUD. They also show bloating, loose stools, and constipation in parallel. They show reflux disease, eosinophilic gastrointestinal disease, and there's also described lately an increased prevalence of celiac disease in HUD patients, 5% versus 0.9% in the general population. So people ask actually whether HUD goes along with a chronic inflammatory bowel disease and constitutes a separate entity. And Konikova et al. Nicely showed 2021 that in the duodenum and terminal ileum, mast cell counts are increased in HUD patients, and also these mast cells are activated. And pyroptose was also increased to the level of patients with morbus Crohn. So these data might point indeed to a separate entity where mast cells might play a major role. You can imagine that there are a lot of differential diagnoses to the GI manifestations in HUD, and I don't want to go through all with you, but I want to make a statement that, in my opinion, every patient that is referred for HUD genetic testing with GI problems and comes to an allergy department actually has to be pre-examined by a gastroenterologist. The treatment of the GI symptoms in HUD is symptomatic with mostly H1 and H2 antagonists. We use desloratadine and famotidine. Proton pump inhibitors can be added if unresponsive to antihistamines alone. Sodium cromolyn is a mast cell stabilizer and can be given before eating. Montelukast and omalizumab have been shown in publications, but also in our hands, to release nausea and also abdominal pain. So what did we do now? Knowing that HAT is linked to severe anaphylaxis, and also knowing that HAT increases the symptom burden in patients with mastocytosis, we wanted to determine the prevalence of HAT and mastocytosis and to describe the symptoms of these patients in our allergy department, because these are the diagnoses that show up in an allergy department. And therefore, patients with a BST level greater or equal to 8 were referred to HAT testing and c-KIT D816V determination in peripheral blood by digital droplet PCR. And as you know, this mutation accounts for over 95% of mutations with mastocytosis. So actually, we came up with a total cohort of 332 patients. And to determine the prevalence of HAT, we had to include patients with known mastocytosis and with a pre-known HAT or HAT in a family member. And for symptom assessment, we had 270 patients, because 270 patients fulfilled the symptom assessment questionnaire. So these are our baseline patient characteristics and the reasons for presentation in our allergy department. And if you look here first to the baseline characteristics, you note that we had a female predominance in our cohorts with 72% over roughly 30% male patients. We had a lot, or most presenters were presenters for urticaria or angioedema, 16%, followed by presenters to work up for BST elevation, insect venom anaphylaxis 9%, suspected mast cell activation with 9%, atopic diseases, and here is meant allergic rhinitis, allergic asthma, and atopic disease. And gastrointestinal complaints, or the referral for this, was, however, less abundant, with only 5.4%, only 18 persons were referred. So first, we determined now the HAT prevalence in our total cohort, which was 62%. We had 35% non-HAT patients. We identified 5 patients with mastocytosis, and 2 patients had the coexistence of HAT and mastocytosis. We then wanted to know the HAT prevalence according to the reasons for presentations, which is seen here. And what you see here in parentheses are the percent. What you see here is, if you look here at idiopathic and other allergies, HAT prevalence according to presentation reason ranged from low as 33% to high as 78%, with patients complaining with gastrointestinal symptoms. A very high prevalence was also seen in patients presenting for BST elevation, 75%, then insect venom anaphylaxis, 71%, suspected MCAS, 67%, and also atopic disease. However, in urticaria and angioedema, HAT prevalence was lower, only with 46%. But you remember, these were the most patients that presented for us in the allergy department. I think that the interpretation of this data must be very cautious, because it has to be taken into account that urticaria patients mostly show up only in allergy departments, and therefore the prevalence of HAT with 50% seems to be pretty high. Whereas with gastrointestinal complaints, these patients have been thoroughly pre-examined by gastroenterologists, and differential diagnoses were ruled out by them. So I think personally that this is a referral bias, but I think especially therefore, allergists are actually in a pole position to detect HAT. So for symptom assessment, a symptom questionnaire was developed that integrated symptoms that were known for HAT and for mastocytosis. We built up 6 categories of symptoms: general symptoms, skin symptoms, cardiovascular symptoms, GI symptoms, pain symptoms, and neurologic symptoms. And each category had 3 specific symptoms. Symptom frequency was divided into never, seldom, regularly was at least once a week, and then often was several times a week. So, and what we first wanted to know was actually the frequency of patients that had shown up with the specific symptoms we asked for, and the comparison was made between HAT positive and HAT negative patients. HAT positive patients are in red and HAT negative patients are in gray. And what you see is very interesting because there were significantly more HAT patients suffering from general symptoms such as fatigue, insomnia, or gastrointestinal symptoms such as diarrhea and constipation in parallel, cardiovascular symptoms, dizziness, tachycardia, orthostatic dysregulation. Also, pain syndromes were much frequent in HAT patients, such as arthralgia, myalgia, headache, migraine, abdominal pain. Also, neuropsychiatric symptoms such as concentration problems, memory impairment, sadness, lack of motivations were all more frequent in HAT patients than non-HAT patients. Secondly, we wanted to know if the symptom burden and also the symptom dissemination were more frequent in HAT patients. And for symptom burden, we categorized the number of symptoms into a low symptom group, into a medium symptom group, and to a high symptom group with 13 to 18 symptoms, and also the symptom categories. You remember the number of organs that are affected. We group the number of the symptom categories to 0 to 2 symptom categories, 3 to 4, and to a high symptom category of 5 to 6 symptoms. And what you can see here is that if you look at the number of symptoms in the high symptom group, HAT patients are frequently more present with 30% with a 13%, whereas in the low symptom group, more non-HAT patients are there with 60% over 38% of HAT patients. And actually the same is true for symptom categories. The HAT patients are more frequent in the high symptom category group here than non-HAT patients, and also in the low symptom category group, the non-HAT patients, like in the symptom category group, are more frequent than in the low group. Okay, so HAT patients actually suffer more frequently from a higher number of symptoms with an increased symptom burden, and the symptom dissemination is more frequent in that group. So last, we wanted to know if HAT significantly might be different for different presentation reasons. And what you see here is that had patients that showed up with urticaria or angioedema and had patients that showed up for atopic disease and had patients that showed up for atopic disease did show much more, a higher number of symptoms that none had patients, whereas this difference was not seen with patients presenting for BST elevation, Hymenopteron venum allergy, suspected MCAS, or patients with gastrointestinal complaints. I come up now with a summary. I want to do a summary now. Symptomatic HAT patients that present to an allergy patient might show an extended spectrum of non-allergy symptoms such as pain, cardiovascular, and neuropsychiatric symptoms. And the extended spectrum of symptoms were significantly seen in patients presenting for urticaria, angioedema, and atopic diseases in our allergy department, and therefore might constitute new clinical phenotypes owing to HAT positivity. In a broader sense, mast cells may have greater effects beyond the known allergy immunology connection, and our data further show an integrative approach to medical practice and not to compartmentalize the immune system. And with these statements, I'd like to close my presentation. I'd like to thank all my colleagues in Lübeck, and especially Daniel Koch, who did all this work for his doctoral thesis. And lastly, I'd like to thank you for your attention, and I'll be happy to take any questions with my email, which is shown here. Thank you very much. Bye-bye.
Very much for this presentation. And I think, is any questions from the audience?
Do we have the chance to ask her directly or not? No.
No, she's not present.
Okay.
The question also in English. So did I get this right? And this HUT or this new HUT thing is something intermediate, an intermediate entity between mast cell activation syndrome and classic mastocytosis, and with the proven hereditary origin.
The hereditary origin, I think it has been proven by the genetic test. I think it's the only way to diagnose this. I don't know, Martin, do you have any experience with this disease? Because I think it's very interesting because they have a lot of symptoms and high burden of disease.
No, I think it's actually captured from you, very right. It's between normal and mastocytosis and a new piece in the field of mast cell activation syndrome. We can identify with this mutation a part of patients who suffer from mast cell activation syndrome, but not all. And the question is, which we could not resolve because it's unexplained, what does this alpha-tryptase pathologically? What in the blood, in the tissue, we do not know exactly what is the effect, or is it only an epiphenomenon. But for the gastroenterologist, it's a very important point to think about your IBS phenotype. Is this IBS phenotype a SIBO patient or is it a mast cell patient? And so we have a very successfully a good new diagnostic tool to classify our patients.
Thank you very much for this comment.
And especially, let me...
Yes, yes.
Yeah, and I think as a gastroenterologist, you have to take this entity into account. If you have a patient with typical urticaria, you test for H. pylori, and you have to think about it. If also inflammatory or irritable bowel syndrome, you have to think about it. If that may be a patient also for this disease. So we are good in time. So We had a lot of allergy, mast cells, irritable bowel disease, so we come to the basics, to endoscopic, to nearly surgical methods in internal medicine, and it's a pleasure for me to hear something about endoscopic resection procedures and closure techniques in neoplastic lesions in the upper GI tract. Yeah.
Yes, Jürgen, thank you very much. And now we go to the gastrointestinal tract. And first of all, I would like to thank the organizers and the VAEM for giving us the opportunity to present on the role of endoscopy today in esophageal and stomach carcinoma. Now here my disclosures, and as we know, esophageal carcinoma is very difficult to treat, with an incidence of 4 to 8 in Germany per 100,000 persons per year. And here we have to differentiate between squamous cell carcinoma and adenocarcinoma. Adenocarcinoma is still increasing in Western world and mostly arises from Barrett's metaplasia. We have also submucosal tumors in stomach and in esophagus, but they are not today's focus. Gastric carcinoma with an incidence of 7 to 13 cases is a higher incidence in Germany, but very low compared to Asia, which have higher adenocarcinoma frequencies. And how does the endoscopist encounter patients with gastrointestinal tumors? And here you can see different situations. We have symptomatic patients with alarm symptoms, which have dysphagia or weight loss, which have to come to endoscopy, and mostly we have here advanced tumor stages. But we have otherwise coincidental findings of a carcinoma because of an endoscopy or for other reason. And we have to make surveillance in patients with high-risk individuals as achalasia or post-resection or post-radiation patients. And there's another point as important for the general population: how do we screen asymptomatic patients? And so we have many tasks to make the modern endoscopy. Now here you see the all-encompassing requirements for a precise endoscopy delineation and then to perform resection. But this slide is a little bit complicated. We go first to the left parameters. We use today high resolution endoscopes with CCD chips with very optical good zoom. With virtual chromoendoscopy, we have also in future and yet today a computer-assisted diagnosis, and we use chromoendoscopy to better delineate the mucosal lesions, the neoplastic lesion, for example, Lugol's Lösung in squamous cell carcinoma and acetic acid for the adenocarcinoma, for Barrett's adenocarcinoma. And in each case, you can also use apart from native chromoendoscopy, also digital chromoendoscopy as narrowband imaging or device from Fuji or iScan to better delineate the margins of such a pre-neoplastic lesion. But along with these improvements in visual illumination of these lesions, also high-frequency generators have improved substantially, as BOA, Olympus, Erbe have developed special modes, coagulation modes and cutting modes as Endocut or Swift spray quark to safely resect within the stomach wall and in the esophagus. And if we make findings and documentation, we should use standardized classifications as Paris classification and also magnifying endoscopy in Japanese. I will talk shortly later. And also the predict classification if you use acetic acid chromoendoscopy. And last but not least, the endoscopy is an important player because he should have much experience in emergency endoscopy, in interventional endoscopy, and also in complication treatment if he makes tumor resections. Now here's the history of the developments for squamous cell carcinoma, and we see a native endoscopy. First of all, we need a sharp endoscopic view to recognize these unspecific reddish lesions, sometimes discoloration or leukoplakic lesions, to discern that here is a pathological state. If this is the case, then we should prompt to chromoendoscopy, as shown here in Lugol staining, showing a squamous cell carcinoma. And Lugol does not deposit in lesions like dysplastic lesions or neoplastic lesions that has a very high sensitivity to screen for squamous cell carcinoma. Now, also not so widespread in Europe, a magnification endoscopy coming mostly from Japan and Asia, which illustrates the intraepithelial capillary loops. These findings, they have been standardized from B0 normal to B1 precancerous, cancerous, neoplastic, and B3. And with these intraepithelial capillary loops, it goes parallel with the depth of tumor infiltration, which is extremely important before we take the resection. And here's the future way, but also some companies have the artificial intelligence-based analysis from neural networks, allowing us to support the endoscopist. What does the computer see? Are we sure is it resembles it as a high-grade dysplasia or low-grade dysplasia? And I think this technique will come in the next years. Now we have very high sensitivities for diagnostic such peculiar lesions. With imaging, chroma-endoscopy have an increase of 34%, and we have here with AI 95% sensitivity to detect these lesions. Now, when we look to such an example as here, exemplified by this picture, which you, if you examine very rapidly, you can overlook this lesion. Here is a macro vessel which terminates at an unspecific reddish erythema. And as you here look, this should prompt the endoscopist to take chroma-endoscopy, going to NBI or to another modality and showing here in the NBI modus, we can clearly see the margins of this squamous cell neoplasia. And here's the B1 lesions with the macro vessels showing that this lesion is preneoplastic. And such small lesions going to the both surface mucosal layers M1, M2 should be resected endoscopically. And if we do this in these small lesions, we have nearly no mortality, while an operation, here an open surgical operation, has a mortality of 3 to 5%. Now, the depth of infiltration is in squamous cell carcinoma very interesting and peculiar and dangerous, as the infiltration depth going only to the epithelium in carcinoma in situ, we have a very low lymph node risk, up to 3.3%. But if the mucosa is infiltrated to M1 or M2, the lymph node risk increases, and you see in M3 involvement, the lymph node risk is up to 12%. And so we have to discuss the absolute indications for resection endoscopically. Is the M1 and M2 layer, if we can proceed this previously before resection, analyzing the B1, B2 muster pattern. And relative, we sometimes discussed also in patients who are older, who have comorbidities, who are no very good candidates for surgical intervention. And if the tumor goes here deeper, in deeper parts submucosa, we have high lymph node risks, and here in this case we have no endoscopic indication, so we should take chemo radiation therapy in these cases. Now, the European guideline for squamous cell epithelium also shows that we have to make a peculiar delineation, evaluation and staging of these early tumor stages, looking to the capillary pattern, to the vascular pattern. And if it is dysplastic or we see only microvascles without greater changes, and we assume the tumor is carcinoma in situ or M1, M2, so it goes to ESD, endoscopic submucosal dissection, as the best method. Now we can discuss in which cases we can take perhaps EMR. But if we have a deeper involvement, as showing here in macrovessels or elongated vessels, loop-like formations, and you see this is a proceeded stage, so we have to go to make staging results with endosonography, CT, PET-CT, and always, if you have a circumferential tumor extension, so this needs a very critical staging, and most patients have to undergo chemoradiation therapy and or surgery. So here we can see the development of the resection strategies on the GI tract from the simple loop snare resections. This is a picture from 1980s, as we had simple high-frequency currents to take out polypoid lesions. But with improvement of the visual examination and illustration, we can also go to flat lesions, to Paris 2C lesions, which can be taken out by cap resection or ligature technique, but also with this very flat to ESD, endoscopic submucosal dissection, with a freehand method to take out a resection. And this prolongs also today from ESD to endoscopic intermuscular dissection, as we can now resect up to the muscularis propria and up to, in some cases, T2 tumors with zero lymph node involvement. And our last option is to make the full thickness resection by this OOTSC cap from firma Ovesco, where the whole wall can be intracted into the cap and taken outside. Now, when going to the endoscopic mucosal resection, as initially described in 1990 years, we have an elevation of the mucosa, and the best lesion for extraction of such neoplastic lesions is by EMR is lesions smaller than 20 millimeters, because you cannot grasp more tissue into such a cap and take it outside. And in EMR we have a very steep learning curve, because the method is not so sophisticated as ESD, and we can use very simple high frequency currents, normal cutting, but no intelligent settings are necessary, as in ESD, where we make, for example, swift coagulation. But the problem of EMR is the fact that we make a resection, one resection, you can say good result of R0 resection, R0 resection, 81%, but if you have to make more resections, the risk of recurrence increases dramatically, and therefore ESD has developed in the last years more and more, and we have now 20 years of ESD also in Germany with good results. Here we can see the problem of the EMR. We have to cut the tumor at different points, and the margins may be sometimes with tumor, other sides without tumor, and the lesion size is restricted to 2 to 3 centimeters. Here is a video of cap resection which we have done in Barrett's esophagus. First the mucolysis with ACC, then the marking of these lesions. So here, this was a high-grade dysplasia, previously diagnosed externally, and we made the EMR, which is here with injection of methylene blue and a good lifting. And if this lifting is very good, you can take it easy with an EMR technique. Here's the snare inside the cap. This allows us to take inside the cap the polyp, and then with a normal cutting current, the resection is performed. This may be done several times, so you can also resect larger areas, but there may be sometimes remaining some aisles, and this may be the cause for recurrence. But this technique has been, I think, 20 years or more successfully been used until ESD comes into our routine use, and so we have also with this method T1 adenocarcinomas removed successfully, and these patients have to be undergo surveillance for the next 5 years. Now, what about the results if you compare EMR and ESD in squamous cell carcinoma? Here, a good study from French, from 5 centers, and they showed as the actual tendency is that ESD has a very higher R0 resection rate, a curative resection rate significantly. The recurrence rate is significantly lower, and the 5-year survival rate is also significantly better. And independent risk factors for recurrence is the fact that when EMR was done, when no radiochemotherapy was before or afterwards included, and if the tumor infiltration was deeper than M3 as shown before. Thus the ESGE recommends us to take patients with M1, M2 tumor involvement both best with ESD more than EMR, and EMR only for very, very low lesions smaller than 10 millimeters exactly. So in Barrett's esophagus, which is shown here and which should be classified by the Prague classification, as you see the circumferential extension and the maximal intention, and here we have used the aceto staining with acetic acid, and you get a fine picture. And in cases where there is no acetic acid, there's a loss of acetic whitening, so we have dysplasia or neoplasia, and we can very good find these neoplasias in flat Barrett's mucosa. In Barrett's mucosa, it is very important that Barrett's mucosa has an additional fourth mucosal layer, a neomuscularis, M4, and the lymph node risk is in Barrett's a little bit lower than in squamous cell carcinoma. Now, when dealing with Barrett's patients, you have to use your best endoscope which you have in your department, using mucolysis with ACC, fluimosil, and acetic acid for staining. And here we see a high-grade dysplasia compared to normal Barrett mucosa. And here, this was a cardiac carcinoma in a patient with food allergy, which was astonishing for us. And if we have the loss of acetic acid staining, so this shows us the neoplasia in Barrett, and otherwise you should also use underwater magnification. And if you think this is easy, this is not easy. From studies we know that for 1 centimeter Barrett length you need approximately 1 minute to carefully analyze this. Now going to this was in the flat mucosa, where we do not see any polypoid or granular lesions. Here is the situation from visible lesions in Barrett's esophagus, and shown as 2 cases with advanced grading tumors. Here G3 tumor, which we had resected in our clinic before, here in this case, but the ESD was unsuccessfully for R0, so this patient underwent 2 surgery. The other case was a signet ring carcinoma many years before. We did here in 2019, and here's a signet carcinoma, also grade 3 SM1, and here we could take it outside with ESD to R0, and this patient could preserve his stomach and did not undergo operation, and we have now many surveillance and no risk and no recurrence has been occurred. The guideline in this case is similarly, but we have a change from EMR from earlier years, now also in the 2020 guideline to ESD, and we look after a careful chromoendoscopic and detailed mucosal pattern analysis. What say we are there differences for deep submucosal infiltration, or is it only at the superficial lining? And if we have flat lesions 2A, 2B, smaller than 2 centimeters, we can make the band-assisted EMR or ESD. If the lesion is greater than 2 centimeters, we recommend ESD because it is better to take the resection area in one piece. If we have superficial submucosal invasion as shown here, and these are T1 and T1 and A and B tumors, so we make 2 ESD in every case, and EMR is no good option. And in cases as shown in the other section by Miss Sophie from the endoscopy, we had another case this week with a T2 tumor going to the deep ulceration in the stomach, and so we have to take complete staging and surgery, and especially in the actual German guideline, a preoperative chemotherapy by the FLOT scheme. Now, ESD is a technical advanced resection method, but it may be very good, similar as surgical resection, if the tumor is superficially located, as here in this case. And we made this with the Boba-Arc 400 generator, marking of the lesion, then lifting the lesion. You can use a special modes for the setting for gastrocut to cut safely in this area with swift go-up, so you have not to push the knife, but you can have a good swift go-up resection. And if it is bleeding, you can use hemostasis forceps, for example, coagulation forceps, but also APC or other treatment modalities. In this context, clinical context, this is done in a CO2 insufflation, always strictly. You have to make the patient for 1 to 2 days fasting, PPIs, and if necessary, antibiotics, and in complication, a CT scan or the X-ray scan. But most patients can leave the clinics at the 2nd or 3rd day. Now, the best optimal target lesion in Barrett's esophagus is flat lesions greater than 20 millimeters, which not amenable for AME. And we have the problem in ESD that the learning curve is very flat, so you need many patients, you need many trainings, and this is worthwhile because the null resection rate is in ESD very high compared to EMR, and the recurrence rate is clearly significantly lower. Now coming to the stomach neoplasias, and here we see the same development historically from EMR resection here from circumscript lesions, adenoma or early adenocarcinomas, up to the EMR technique with taking it out with the incision and submucosal preparation. So we have a great resection defect in stomach which may come to bleeding or perforation. But in the first studies with EMR, also endoscopic mucosal resection, we had the aim always to resect the lesion completely. And so we had criteria to take out early stomach carcinomas if they are smaller than 2 centimeters, non-ulcerated, mucosal carcinoma and intestinal type G1 or G2. This was in the EMR area. And now with the ESD area, we have developed more criteria and more advanced criteria to also go to exceptional cases and make advanced resection criteria, as shown here from the German guideline. Last update was 22, so we have non-ulcerated neoplasia in the stomach, smaller or greater than 20 millimeters. Also, if it is an intramucosal carcinoma, maybe greater than 30 millimeters, no ulceration, we can make the ESD with good results, and we have to look to the grade G1 and G2. If it is a very good differentiation grade, you can safely try the resection. We do this always in comparison and discussion with our surgeons, because if we have an incomplete resection or we have a perforation, the surgeon should know this patient. And in this case, this data came from great statistics from lymph node analysis, especially Gotoda and ICEA, but also newer data, which showing we have here very low risk risiko situations in G1, G2 tumors, smaller than 30 millimeters, and even if ulcerated. And also a low risk of lymph node involvement of 3% if the tumor is greater than 30 millimeter and ulcerated. And even, which is always discussed in the tumor boards, if we have a G3 tumor and no differentiation, you can make ESD if the tumor is smaller than 20 millimeters and non-ulcerated. And these cases are really important because we often get old patients, 85 years old, who are poor surgical candidates, and in this case, ESD is very worthwhile to make this. Now, when coming to the results in the stomach, now we have a huge amount of literature showing that we have a high rate of en bloc resections, greater than 90%, also in the Europe centers and in Asia. We have in our clinics, and together with University Erlangen, with Professor Mais, I think we have more than 1,000 ESDs performed at the lower and upper GI tract. The recurrence rate is low, between 5%, if we have a low zero resection, curative resection 75 to 90%, and some patients need to be retreated, which is not bad because endoscopic retreatment has a low mortality rate. Otherwise, if it is a G3 differentiation and the tumor goes deeper, so we have a surgical follow-up and a resection. Now the complications are in post-ESD bleeding 5 to 10%, and perforation is 2 to 5% higher than in esophagus, but we have also here some improvements of post-resection management. First of the bleeding, and second of the covered perforation, as shown here, may be deeply covered perforation. We can close this with the over-the-scope clip. But the developments, ladies and gentlemen, are going further on, and we are now on the step to come to lesions, to closure them by a thread, taking here inside under the endoscope with a special needle holder with a thread, and take it around the resection area and then close it as in a surgery. I have shown here a short video from our last training at the Malteser Waldkrankenhaus. As you see, this is a rotable needle holder which is guided by the endoscopy nurse, which should be very trained in this situation, and the endoscopist can gently form the endoscope to take, as similarly as in surgery, the needle and close such a lesion. And we have now to ask which patient should be closed. A patient who needs anticoagulation, for example, should every resection area be closed, or should we only close if we have a perforation? But this is a very important point to make future training and to improve ESD outcomes. Here's another, the company from Boston has also developed a new device which we trained in the endopraxis days in January, as shown here. Some tags are here inserted into the pig model, and in the tags we rotate inside. There's also a thread taking the hole, and this was a perforation, and coming inside with this device, and then gently it is taken outside, and you can close it as similarly as in surgery. So I'm very happy, because my first aim was to go to surgery. Now I stay here for endoscopy, and we can similar things. So it is a very nice task to work in endoscopy. In summary, ladies and gentlemen, the detection of early neoplasia needs an attentive endoscopist. You need some time, and you should make the optical refinements have helped us to diagnose really very early neoplastic lesions. The decision on endoscopic therapy requires on your assumption, goes the tumor deeper in squamous cell carcinoma M2, M3, in adenocarcinoma SM1, SM2, and if we feel this is possible and we have a good result from the tumor board, we can make the ESD or the EMR resection, and always we have to analyze the pattern of the surface of the tumor. Now here you can see the summary of the indications, of the current indications which we do in our clinics relatively frequently, as I shown in squamous cell carcinoma M1, M2, EMR only if it is a very small point. Otherwise we always use ESD, and in Barrett's adenocarcinoma, so you can sometimes take 10-20 milliliters. Here's the size limitation not so strong as in squamous cell carcinoma. And I also mentioned to you that we are able or even allowed to take undifferentiated G3 carcinoma outside if they are very small, smaller than 2 centimeters, and are not ulcerated. Thank you very much.
Thank you, Martin, for this excellent overview over the development of endoscopic resection in early malignant lesions. Are there any questions from the audience or from the chat maybe also? Okay, let me ask some, are there also hybrid technology between traditional mucosal resection and ESD, which you prefer in some cases?
Yes, hybrid techniques are discussed actually on the European Week in gastroenterology, but we have to differentiate between European and Germany. In Germany, if you do two different methods, you are only paid for one method, not for the combination. But sometimes if we have a polypoid tumor, we can make it by EMR smaller, and the flat area is taken out by ESD. Similar in the colon, we have to make the possibility to take outside with EMR the polyp, the polyp lesion, and if there is a flat area or a scary area, then we go with the FTID to make it outside. But it's economically for the clinics in Germany not very good.
Okay.
Maybe for me, short question: artificial intelligence. Are you using this method for detection
No,
as a standard, or what is?
I think the standard
European?
will coming with artificial intelligence analysis, but we have to be critical. If you have newcomers in endoscopy and they work with AI, they do not learn the very sharp endoscopic view initially. You have first to learn initially how endoscopy and how to recognize pre-neoplastic lesion. And if this is so, you can implement AI for supporting your diagnosis or the vision. But we cannot go that the endoscopist depends only on AI, because there may be several mistakes inside, and also many false positive lesions, because there is an inflammatory polyp. It says also take it outside.
That's a very important point. There was a nice study taken in Germany with eye tracking systems, which shows clearly that endoscopic novices will not focus. They rely on the artificial intelligence and not on their eye, and they will not look as fine as it is usable. Yeah, okay.
Otherwise, we cannot stop the technical developments, and we can from Asia. We have an AI system which shows you in the Barrett's neoplasia. And the next step, the computer gives us the borders how to resect. So he makes then a suggestion for the endoscopist how to resect safely with 1 to 2 millimeter distance. I left this in the presentation due to times, but these developments will come on in the future, and we have to deal with this.
If there are not further questions, we can follow with the next.
Yes. Dr. Pfisterer, he accompanies now us as a chairman of VAEM. Please. Please, no.
Next speaker will be Professor Jarisch from Vienna. He will referate about histamine intolerance, relevance for allergic and post-infectious disease. Please.
Dear Chairman, dear colleagues, I was asked to give this lecture in English. However, I think it would be also good to have it in German. And due to artificial intelligence, my oldest son will translate my talk into German, and we should be able within 2 or 3 weeks to provide you with a German version. I like Colombo. Have a nice day. Is that good, isn't it? Yeah. I'm coming from Vienna, Floridsdorf Allergy Center. These are my colleagues. And the talk is about histamine intolerance, relevance for allergic and post-infectious diseases. Greetings from Vienna, one of the most livable cities in the world. I live there, I know what I am talking about. And the Floridsdorf Allergy Center is just beside this big tower on the right side, so in a very nice area. The most important person dealing with histamine was a German investigator, Wilfried Lorenz. And for his work, I would think he should have earned the Nobel Prize, because this was very, very important. And he brought me to be engaged with histamine. The experiment he did was, he had 2 groups of pigs, and one group received a blocker of the diamine oxidase, and both groups afterwards received histamine. And as you can see on the left side, there is a difference in skin color, and this was the group with anaphylactic shock, and most of the pigs died. So what did it say? It says us that the level of the diamine oxidase is important to survive, and at that times it was a difficulty to determine histamine from the blood and even the diamine oxidase. Finally, there was a French test for histamine, and we ourselves investigated in the diamine oxidase and invented a test so we could do this work. Together with Professor Raithel, where is he? Over there. We presented more than a decade ago a book, and you see we have been #1 in allergology at that time. In the meanwhile, we have a 4th edition and also an English version. What is histamine? If you want to explain to a patient what is histamine, you say, well, this is the nettle, and if you come in contact with the nettle, then you will get histamine in the skin, and this will lead to erythema, urticarial lesion, and itch. The degradation of histamine mainly can be done by oxidation. This is the diamine oxidase, and by oxidation due to vitamin C, which is mostly unknown but important. The clinical symptoms start with headache, migraine, congestions of the nose, bronchial asthma, tachycardia. Hypotension is important. A patient with histamine intolerance typically suffers from hypotension, then cramps, the diarrhea, and the skin lesions we have already discussed. It's typically in female patients with the age 40 years plus minus 5 years. This makes 80%. So on the other side, 20% are men, and some even children. And it may occur after the intake of some drugs, which I will discuss later. How to make the diagnosis? The first is the case history. You have to think about it and on it. Then blood taking to determine histamine and the diamine oxidase. Then a diet for 14 days, a histamine-free diet, and then again blood taking, and you ask the patient how he feels and if he improved. We give the patients an indication, a list of foods which should be avoided, and especially it's easy to say you can eat everything which is fresh, without tomatoes, no pizzas with tomatoes, no tomato juice. And if you examine that, you see that after histamine-free diet, you see a significant decrease of histamine and a highly significant increase of the diamine oxidase, which is the enzyme to decrease histamine. This is a list of drugs which might block the diamine oxidase. Most important, augmentin and the pain-taking metamizole can be seen. This is a case where we had a young patient, 24 years of age, with allergy immunotherapy with no side effects for 2 years. And then suddenly, after the 21st injection, he developed anaphylactic symptoms, and the case history revealed that he took ACC, which is a drug which might block the thiamine oxidase, and after some weeks everything was okay again, all levels were normal. I think that histamine intolerance can be seen as a minimal form of anaphylactic shock, and addiction death are in vivo model for anaphylaxis. If a patient with after drug intaking dies, most people think this was an overdosage. No, it was not. It was vomiting, and these people inhale what they vomit and they die. And we investigated patients being on under substitol for the treatment of their drug inheritance, and you can see even in these people all the relevant parameters like histamine, the DAO, tryptase, and lipophospholipase A are significantly pathologic. What we did in another study is we gave healthy normal persons histamine, and as you can see, within these 10 persons, 6 persons developed symptoms. And what were the symptoms? The diarrhea was number 1, and sneezing, running nose, meteorism are other symptoms which might occur in healthy persons. As I mentioned already, vitamin C is able to decrease histamine, and here you can see the more you increase the vitamin C level, the more you see a decrease of histamine. Histamine of headache is important because you should know that this might be a cause of headache, and the easiest way to try to prove that is to make a diet, a histamine-free diet. And if you do so, you see after 1 month a decrease of histamine, an increase of the thiamine oxidase. And the interesting thing, the average of headache at the beginning was 14 days per month. That means every second day. And after 1 month of the diet, 2 days per month. And taken together from the 35 patients, 22 were completely symptom-free. In 8, we saw an improvement of 50%, and only 5 failed, so it's worth doing it. Histamine and atopic dermatitis, also in atopic dermatitis, we find in half of our patients a reduction of the SCORAD points. Now coming to post-infectious spermidine levels remain reduced over a prolonged time of period after viral infection. I heard a talk about long COVID. All the symptoms have been mentioned and there is no treatment. And then the lady said, typically for long COVID is the loss of hand power. Hello? Loss of hand power? We know that from dementia. And typically for dementia is a low spermidine level. So here you see with increasing age, the spermidine level goes down. And what is also important to know that at the Charité in Berlin, Professor Drosten showed that if you give to a coronavirus culture spermidine, 87% of the viral of the virus were killed. 87%, that is a high percentage. So we developed the following hypothesis. COVID-infected patients already had a low spermidine level prior infection and still or even lower after infection. This was the hypothesis. And we also invested chronic fatigue syndrome patients to check is there a difference or not. And what you can see in chronic fatigue syndrome patients, the spermidine level was decreased. Very important, because if I find a low spermidine level, this means not only the diagnosis, it also means the treatment. You just have to add spermidine. We also checked the IgG levels, and there was no significant difference, which is logical because they didn't have an infection. So chronic fatigue syndrome is not related to coronavirus infection. And then we checked spermidine levels in convalescent after COVID. And as you can see, long COVID patients and convalescents have a low spermidine level. And we checked the IgG levels, and long COVID had the same IgG level as healthy controls, and the convalescents a high amount of IgG levels, and that's the reason why they got healthy again. So taken together, chronic fatigue syndrome patients show a significant lower spermidine level compared to healthy controls, but the same SARS-CoV IgG levels compared to healthy controls, since they did not have COVID. Convalescents after COVID show a borderline lower spermidine level compared to healthy controls, but a significant higher SARS-CoV IgG antibody levels compared to long COVID patients. So long COVID patients are characterized by a borderline low spermidine level, but significant low IgG antibodies. We therefore propose determination of spermidine in the serum and IgG antibodies as a diagnostic tool for long COVID and chronic fatigue patients, and spermidine given for 4 weeks as a treatment option. And what is the treatment option? 1 soup spoon wheat germ a day for 4 weeks should normalize the spermidine levels. Interestingly enough, some long COVID patients develop histamine intolerance. And I do not know why, and so far I have no idea why, and it might be, and most likely be, due to a massive loss of vitamin C, which is able to decrease histamine. So, all clear, and this is the end, and if you want to read more about my ideas, I just going to publish a book within 1 or 2 weeks, and this is in German, wie ich als Arzt lernte, Columbo zu werden. Thank you.
So you would have to ask a last question by going outside. Are there any questions from the audience?
What is your theory about the connection between COVID-19 and histamine intolerance? Because probably you don't know. Do you suppose any? Yeah.
I just mentioned it. It's a fact that I would say.
The link with gut microbiota, for example.
About 20% show histamine problems, but I have no idea what the reason behind is, and my speculation is low vitamin C level, but we have not checked that.
A short comment in this case, Peter and Reinhard. From our experience, we have examined several patients with the ME, CFS, and long COVID, and what we found that these patients may be predisposed before COVID with clinically inapparent high mast cell number, and they get relatively bad causes. And if there come further points together as low spermidine level, low vitamin C, or an atopic conditions, so this may go worse.
On the other side, there was papers showing that people with allergy are not so susceptible to COVID infection.
Yeah.
So
if they are treated with H2 blockers,
okay.
so they have a better prognosis.
prognosis, okay.
And there's a clear in the literature, some hints that the H2 blocker is beneficial in this case.
Thank you very much.
So have I understood correct? If you have a patient with a long COVID syndrome, you would propose a treatment with spermidine in every patient or not?
Yes.
Okay.
I would like to see one of your last pictures about the treatment, please. In your presentation, I would like to see one of the pictures, or the last ones, please.
Which picture you want to see?
About the treatment, please.
The treatment, it's spermidine, and this is wheat germ.
Oh, the one before, I think.
You mean that?
The one before that, please. Ah, yes,
No?
this one. Thank you. Exactly, that one. Thanks.
Yeah? Okay.
Can you show this one? Yeah, this one. Thanks.
Oh, they want to make. Okay.
To summarize these different options for treatment, we have immobile patients in our clinics, and we have to perform multimodal treatment. So this means spermidine substitution, vitamin C substitution, giving H2 blockers, making enteral nutritional support, and so you can get better results. This should be all combined measures to get a patient outside of this very immobilized state.
Maybe last question. The fatigue is a big problem also in inflammatory bowel disease or IBS. Do you think that spermidine could be a solution for patients, therapy with spermidine with fatigue?
Yeah.
Yeah.
Short answer.
It makes sense. Okay.
Yeah, very interesting talk. Can I ask about your theory how spermidine would work? I mean, what is the mechanism? Is it increased autophagy, or why do you think spermidine is protective for COVID infections or MACSF?
The question was why it works. I don't know, but it works. Actually, I just want to know if it works or not. It does. And other people may investigate it why. And for instance, it's for the patient. The patient only wants to get healthy again, not why and what is the background. I want to be healthy again.
And let me ask, what do you say patient with celiac disease? They couldn't eat wheat germ.
Yeah, but you can buy spermidine in capsules in the pharmacy.
Okay.
No more question? Thank you very much, Professor Jarisch, for this interesting lesson. It was very interesting. Now we have a short break, and you can visit the industrial exhibition, please.
Thank you very much.